It's my sincere pleasure today to be with a wonderful group of panelists regarding review of some GI cancer cases. My name is Dr. Kathy Ng from Vanderbilt Ingram Cancer Center, the David H. Johnson Endowed Chair in Surgical and Medical Oncology, and the co-director of the GI Research Program. Today we have some wonderful panelists, and we'll just go around and have them introduce themselves. So please introduce yourself, Carrie Siegel.
Hi, good afternoon. My name is Dr. Carrie Siegel. I'm an abdominal imaging radiologist at Washington University in St. Louis.
Hello, everyone. My name is Al Benson. I'm a GI medical oncologist at Northwestern University and the Robert H. Lurie Comprehensive Cancer Center, where I serve as one of the associate directors.
I am at Emory University and Winship Cancer Institute. My focus is primarily complex upper gastrointestinal and hepatobiliary surgery, and it's a pleasure to be here today.
I'm Pritesh Patel. I'm an associate professor of radiation oncology at Emory University. I work closely with Dr. Kubi. Glad to be here today and to discuss some good cases.
We have a young patient here with a well-differentiated pancreatic neuroendocrine tumor. I know Dr. Benson loves neuroendocrine tumors to discuss. This is a young woman with a history of liver metastasis and had received capecitabine and temozolamide, followed by maintenance lanreotide, status was distal pancreatectomy and cholecystectomy. She was found to have a solitary liver metastasis 2 years later and treated with an MRI-guided tumor ablation. And now she has some evidence of slow progression. As she originally presented with abdominal discomfort and intermittent loose bowel motility, the performance status was 0. She has no other medical history. She's married, she's a non-smoker, and drinks about 2 to 3 alcoholic beverages per week. Family history is non-contributory. Dr. Siegel, can you please comment on this initial imaging that was obtained?
Sure. This is one sliced portal venous phase CT, and you can see there's a low attenuation lesion in the pancreas. And also here there's sort of, I don't see the splenic vein extending across. I'm not sure if the mass is occluding the portospinal confluence. There's also multiple liver lesions. If you look at the right kidney, directly to the right of it, there's a low attenuation lesion, suspicious for a liver metastasis. And then extend out farther to the right, there's another low attenuation lesion. And then in the liver anterior aspect of the liver, there's another sub-centimeter low attenuation lesion. And in the region of the falciform ligament, there's an area of low attenuation that is probably just focal fat. So again, a pancreatic lesion with probably 3, at least 2 suspicious liver lesions.
Thank you so much, Dr. Siegel. So a liver biopsy was obtained. It was consistent with a well-differentiated neuroendocrine tumor, grade 2, Ki-67 between 3 and 20%. Started on Cap-Tem, so capecitabine and temozolamide for 6 months, had a wonderful response. The primary pancreatic tumor looks like a scar, and reportedly liver lesions are not visible. I know this image is a bit fuzzy, but Dr. Siegel, do you care to comment?
Sure. This is a portal venous phase from a dynamic FAT-SAT MR. It's the equivalent post-contrast MR to the post-contrast CT we looked at a minute ago. And that low attenuation mass that we saw in the CT is either gone or near gone in the body of the pancreas. And if you remember, there was a lesion just to the right of the kidney and another one farther near the right lateral liver margin. All of those are gone. So really dramatic response.
Thank you so much. So now the patient's undergone an extended distal pancreatic and cholecystectomy. Imaging 1 year later on demonstrates no evidence of disease. Dr. Siegel, can you confirm that?
Yes, well, it is one slice, but you can see this is more of an arterial phase from a dynamic MR. And there's post-operative changes in the pancreas. The margins look excellent. The pancreatic head is free of mass, and the visualized portion of the liver is tumor-free.
Thank you so much. So imaging 2 years later, unfortunately demonstrates a solitary liver metastasis, and she was started back on lanreotide. Oh, I'm so sorry, Dr. Siegel, please comment.
I was just going to say, this is also an arterial phase fat set from a dynamic MR sequence, and there's a target-shaped lesion in the right lobe of the liver with sort of an enhancing center, and then sort of a low signal intensity margin, and then an outer enhancing rim. And I was just going to make the comment that these targetoid enhancing lesions are never good ever in the liver.
Dr. A, can I make a comment?
Yes.
Just one comment on, whether surgery for the pancreas, given the scenario that this patient had multifocal liver disease, was necessary or appropriate, and sort of what are the steps, because that's a good part of the discussion from the surgical aspect. And because the patient's 38 years old and had such a wonderful response to the original therapy, I think that's the surgical mindset to go ahead and clear the extrahepatic disease. And in this scenario, I just wanted to add, typically as the surgeon will also take the gallbladder out, so that if we leave consideration for regional therapy for the liver, that it makes it easier on the interventional radiologist. I just wanted to add that.
And I think actually that's one of the questions that was supposed to be coming up. So that works quite well. So she then underwent 2 rounds of a tumor ablation, and unfortunately now demonstrates some evidence of progression. So these are multiple questions that were posed. So Dr. Benson, what order of medical therapy would you recommend in this setting?
Well, even though this is grade 2, the patient appears to have a very slow progression of disease over a few years. It does look like low volume disease. So you could argue, if the patient is asymptomatic, to just follow and monitor, and then if there's further evidence to proceed with additional therapy. I'm assuming a receptor nuclear medicine scan was done, such as a gallium-68 dotatate PET CT scan, because that would be essential information if you're using either lanreotide or octreotide as somatostatin analog-based therapy, which for patients with receptor-positive disease is often the initial therapeutic approach. So I would want to see the gallium scan. Furthermore, a gallium scan can often demonstrate more disease than we see on imaging. In fact, we can pick up bone mets that are silent but weren't clearly delineated on other imaging. So we would want to get a sense of the extent of disease, particularly if we want to confirm this is liver-only disease in terms of the best of what we can see. Because if there is liver-only disease, like at my center where we've done extensive research together with our interventional radiology team, we work very closely, and we might even consider, for example, yttrium-90 radioembolization as a potential, or even if they're very limited liver lesions, even radiation. But as typical of neuroendocrine tumors, people tend to get multiple liver lesions, and therefore more isolated treatments, whether it's radiation or ablation, are usually not indicated. This patient, though, would have multiple other choices of therapy. So if it was demonstrated temozolamide and capecitabine gave a great response, you could go back to that. For pancreatic neuroendocrine tumors, there's also everolimus, sunitinib, and of course, PRRT, which is perhaps the most successful systemic treatment developed to date, based on the NETTER clinical trial results as published in the New England Journal, which led to FDA approval.
How do you decide on the sequencing when you're thinking about the role of PRRT, since it is quite successful?
So I think it's very appropriate for many cases if they progressed after somatostatin analog therapy and their disease is clearly positive on receptor-based imaging. I think that's a very appropriate second-line treatment. There's a question as to people with high volume disease, do they get maximum benefit from PRRT? But currently that would be certainly a very appropriate second approach. However, as I mentioned, if it's liver-only disease and interventional radiology says that with these very vascular tumors that bland embolization, chemoembolization, or radioembolization is a consideration, that would be fine also. So at my center, I think we tend to lean more toward those approaches first, but I also think going back to capecitabine temozolamide is very appropriate consideration, and this would need to be reviewed carefully with the patient, what was their tolerability and so forth. You do worry about temozolamide as well as PRRT in terms of the impact on the bone marrow. It's a low risk, but nonetheless a risk of MDS or even leukemia. So those have to be considerations.
And there are ongoing trials right now with PRRT in combination that are investigational, if I'm correct. Is that right?
Yes, yes. There's tremendous interest in how we can further obtain benefits with PRRT. You know, and although PRRT results are quite impressive.
Thank you so much. Dr. Kuby, this young lady that now has had a slight progression in this liver lesion that has been ablated in the past, how would you like to address it?
You know, just in terms of general discussion with this patient, as soon as she comes to see us the first time, you know, the elephant in the room is this is not a disease we're going to cure, but it is a disease where if we use the right weapons, we can set the clock back and get some real benefit for the patient. So, you know, if the patient had limited disease to one side of the liver or one region of the liver or various lesions that were controllable and not progressing quickly, one could consider local resection of the lesions combined with intraoperative ablation. And then, you know, if they were confined to one side of the liver, or right or left hepatectomy. But in a scenario where maybe they're progressing in multiple sites, we would probably not approach that, since we do have very reliable now medical options available. Being that she's a 38-year-old woman, you know, also pulling the trigger on PRRT has some other implications for her as well. The last thing I would say is if she had multifocal disease and 6 months stability and it was less than 25% the volume of the liver, and I don't know about maybe progressing on PRRT, one thing that could come up in discussion, although it's extreme, would be liver transplantation.
Interesting. Thank you. And then Dr. Patel, this young woman with this slight progression, do you have any comments about how you could potentially contribute to her care as well?
Yeah, thanks. You know, it is, as Dr. Benson, I think, alluded to, it's not common that we're finding sort of just a small volume of disease. So certainly external beam radiation, if it were to be considered, would be reserved for those that have just a handful of lesions that could be accurately targeted. So with multifocal liver disease, typically maybe radioembolization would be a more appropriate choice. But if there were to be a single progressing lesion, or one or two or three, typically, we would consider SBRT, which would deliver an ablative dose of radiation. So I think, we do worry a little about the more slow-growing tumors and their response to radiation. But with SBRT and the high doses that are now achievable, I think there's an anti-tumor effect, but also a vascular effect, where we're pretty effective at ablating the zone that's treated. So we have done that on occasion, but it is pretty rare with this histology.
Thank you so much. And then
Dr. Ang, I would just add, with capecitabine temozolomide, a recently completed ECOG-ACRIN trial that compared that combination with temozolomide, showing very impressive results. And this patient would be a good example of some of the responses we can see with that combination.
Thank you so much. And then Dr. Siegel, for this young woman, she's now had recurrent disease. What is our best imaging that you think to follow this patient? Because we suspect, obviously, she's going to either, if we choose to observe her because she's asymptomatic and she's had slow progression as initially presented, or we will resume her treatment. Are we doing the best job with recurrent imaging?
I think we are. There's a lot of different imaging options, and I think there can be different options for different referring physicians depending upon where they are and what's best at their institution. I think the reason why I like MRI the best is we can not only get dynamic information for the liver and the pancreas, but our diffusion imaging is really good in that our high B-value diffusion imaging, those are the images that you see that look kind of blurry, but we get them on all of our abdomen and pelvic images. And pathology is usually very bright on the high B value. And what you'll do is you'll take anything that's a bright dot and then triangulate over to the pre and post contrast images and get some more morphologic information. Is it a nodule that's enhancing? Is it a new lesion in the liver? And also with hepatobiliary phase, MR contrast agents, we do an excellent job looking for liver metastases, and we can compare to prior and then in the future to other hepatobiliary phase images. They're excellent. So I think MR is the way to go, but I think in certain situations, I think CT can perform an absolute fine job.
Thank you so much.